Very much, Frank, for inviting me again. I'm sorry for not being able to be with you, but I'm going to talk about my experience with inner branch and outer branch for thoracoabdominal aneurysms after thoracoabdominal dissections, technical tips and results. Those are my conflicts. I brought this slide here just to remember you that the technique was described in 2001, so more than 22 years now. And if you look in the literature, there is more than 1,000 publications on PubMed. I'd like to draw your attention to this paper that we published in 2008 in the Journal of Vascular Surgery, and we show our first 36 plans in this watch model. We show the coincidence of the branches. I think that was the initial step for an off-the-shelf device, although not very well recognized or published in the literature. Almost in the same year, we published in the Journal of Vascular Therapy 2009 the use of 3 devices that at that time the devices were CMD, so we lost 3 patients, and we were able to use these 3 devices in another patient. So I think these papers means the first off-the-shelf devices used in thoracoabdominal aneurysms. We do not mention any more about the patency. This very nice paper published in 2016 by Eagleton, Taaa, Mastracci, and they show what is important is here below that the patents primary plus assisted was 90-80%. That means they work. This was also recognized by the paper of Eric Verhoeven in 2015 in the European Journal. So as his conclusions, the endovascular repair of the thoracoabdominal aneurysm with fenestrated and branched stent grafts in high volume center. I think should pay attention to these high volume centers. That it means people with well-trained and a good level of experience. Also brought to you this systematic review published in 2022, and the authors shows that there is a paucity of relative data, and there are no randomized clinical trials for a thoracoabdominal aneurysm, which I think is also true for thoracoabdominal aneurysms post-dissections. So there is a great disparities between the patients. I think the endovascular patients have more comorbidities, so it's very difficult to compare. So about the tips, I think it's important there is a step-by-step how we do that, but the most important is when we implant the graft, we prefer the gradual opening because, especially for narrow aortas and dissections, you have a lower ischemic time and the limbs, and this is very important for the inflammatory response of those procedures. Even knowing there is a tendency to do that by femoral, we can do that, but remember when we do that, we're going to have a clamp in both femoral arteries and increase your inflammatory response. That is an advantage of using the T branches, that you modify the T branch. Even in the just arena, we can open the windows behind the graft to perfuse, get more perfusion in the intercostal arteries. You can also use the snare ride maneuver, so to bring your wire inside the target vessel. That helps a lot. The Disadvantages compared with CMD devices, we all know, is the French size, the only 4 branches, and the only one diameter. I know the cookie industry is going to move that and have more sizes and lesser diameter, so that will be better in the near future, I hope. Let me finish my 6 minutes. I just show you that we did this treatment in 2011. I think it was the first dissection treated with a 3 branches device. It works very well. You can see that that it was entirely remodeling of the aorta just after 9 months, which was very surprising for me and all other surgeons, including my friend Joe Kuzak. You can see it was a very durable procedure. We have these patients 8 years later with excellent patency and totally remodeling of the aorta. You're going to see more difficult patients as this one with previous aortic surgery in the scene here. So you have to plan. As I said, planning is everything. So we just plan to go to do small communication with the celiac branch to the renal and then use the other branches for the other vessels. The result was excellent. You can see that his early CT scan with all the branches well perfused. And that was the final result with all the branches perfused, except that he developed a NASH aneurysm that we treat even knowing he has a very small lumen in the aorta. I just remember that when we have an angulated device, so angulated the aorta, the true and true wire helps a lot. To finish, I'm going to say in our center, that's the gold standard for treating those thoracoabdominal dissection. Sorry for going over a minute over the time, and thank you very much for the opportunity.